Hi, good evening, and welcome to this CPDme webinar on this fabulous Thursday evening. What else would you want to be doing on a Thursday apart from joining me and Rusty Carroll on a leadership webinar? So, good evening, welcome on board. It's great to have you all. I can see people are currently coming into the room. And I'm going to tell those people who've never been here before what this is all about. So this is a webinar, which means we can't see you and we can't hear you. So if you are pottering around in your terry toweling dressing gown, or indeed you've just come in and you've not had a chance to do your hair, then don't worry, because we can't see you. And equally, we can't hear you. But if you have got any questions tonight, please do pop them into the Q&A box, which you'll see either at the bottom of your screen, at the top of your screen, or floating around if you are on a mobile device. And it's also great equally if you engage with us in the chat. So I always invite people at this point maybe to pop in the chat where you're dialing in from tonight and what interests you around leadership. If you are a member of CPDme, then of course you will get your CPD certificates automatically, and that will come in the morning when my fabulous team arrive in the office and have had their first cup of coffee. And of course, everybody will get a copy or access to the recording, and we are equally also live on YouTube, so you can always jump on there and catch up later. And the magic occurs, of course, because your CPD certificate and the evidence will of course drop into your CPD portfolio, which makes recording at CPD super simple, as long as you go in and reflect, of course. If you are a social media fan, I had a go at TikTok last week, which was quite entertaining. Needless to say, it never made it to public release. But if you are an avid social media fan, then please just simply follow us on Twitter. It's always good to have new followers. And also, if anything's hot off the press, we will pop it on Twitter generally before we pop it anywhere else. So maybe a picture of yourself tonight with your dog or your cat, or maybe your husband or your wife, in fact. Maybe holding a cup of tea, peppermint perhaps, glass of wine, however you choose to have your relaxed learning. Share it with us at CPDme with hashtag CPD Made Simple. If you struggle to record your CPD, like I know many people do, then please do consider downloading the mobile app, or even better, join us as a premium member, because I will guarantee word for word, I will make recording your CPD simple for the rest of your career, for as long as you have to, in fact. And if you're anything like me, as I was back in 2009, I was pretty good at being a paramedic, pretty terrible at recording CPD. And so that's where CPDme was born on the 3rd of November, in fact, 2009, at 11 o'clock in the morning. But please do scan that QR code, or you can jump over to cpdme.com. You can have a $1.99 trial. It's almost like taking a motorbike out. You're going to love it or you're going to hate it. And if you don't like it, we'll give you your $1.99 back at the end of the month. We're that confident that you'll like it and make recording your CPD simple. YouTube, again, for our social media fans, we always go live to YouTube if we can, and that allows us, if we get full, for people to overflow and pop over there. And we also pop some really good videos on there too. So please do have a look at our YouTube channel, or you can subscribe at youtube.com/CPDme. Now, you know, I love a little competition giveaway. I normally have lots of giveaways around me, but again, we are jiggling the office around. So they've put me in the corner, which means I can't show you any giveaways, but I will give you some giveaways, because I like to give giveaways away on these webinars. But I do need you to leave an honest and appropriate review on either Trustpilot, on the Google App Store, or indeed on iOS App Store or Google itself. And I will give away 2 £25 Amazon vouchers, which would normally be sat on my desk, but my desk is pretty clear because we're having a shift around. But I will give away one tonight at the end of the webinar, and I'll give away one live on Twitter tomorrow. So please do leave us a genuine review on any of those 3 platforms if you've used our system or indeed enjoyed our webinars. If you are a CPD champion, always good for you to download our poster. If you download it, we'll make sure you always get the latest poster. So once a month, we'll email it you to share at work. The strangest place I've ever seen one is the back of a toilet door. And I think that was prompted by Dawn on a previous webinar. But yeah, I've seen them in some pretty wacky places. And again, the team will look on social media. And if they do spot one on your notice board, there's usually some giveaways. We've got lots of cups and stuff to give away generally that we'll send in the post to you. There is where you can download our mobile app. It's available for Android, iPhone, tablet, iPad, and pretty much any other platform that you can download on your fantasy mobile phones. But please do scan it. It really does make, number one, recording CPD simple, but it equally makes jumping onto these and registering for these webinars literally one single click. That's enough talking from me. I'm going to hand you over to Rusty Carroll now, who looks poised and ready. Are you poised and ready, Rusty?
Andrew, I after all of that, I'm really struggling to know how I can follow that performance. However, I will try my best. So, good evening, everyone. My name is Rusty. I haven't seen anyone in the chat that I recognise yet. In fact, I've just lost vision of the chat. I'll recover that in a second. As Andrew's introduced, I'm here to talk about leadership tonight. We've kind of broken it up across 4 sessions. Each of the sessions will stand alone, but equally there will be themes and an arc across the 4 sessions. So for those that can, I'm also delighted to see what a broad range of professions we have represented in the audience. I had initially assumed it was going to be largely a paramedic audience, and I'm delighted to see that we are joined by many others. So do a little bit about me, because apparently that's expected. So I'm a paramedic by background. I became an ACP a couple of years ago. And yes, for the paramedics out there, yes, I'm a prescriber because I work in primary care, and yes, it's terrifying. And that's all good, because terrifying can be absolutely what you need sometimes. About 16 months ago, I somehow ended up as the clinical director of the primary care network that I work in. I am the only paramedic clinical director of a primary care network in England, and it is an English thing, primary care networks, because it's NHS England, that I'm aware of. If anyone knows of another paramedic that's out there that's a CD, it would be great to have someone else to link up with and network with. But in somewhat of an unusual position, when I can see there's at least one person who's a trainee ACP out there. Lovely to have you on. When I started out my journey to become an ACP, I started out on a master's pathway, and I didn't really know where it was going. The job I'm doing now, in fact, most of the jobs that paramedic ACPs are currently doing didn't exist at the point where we started out our master's pathways. So for those of you who are out there thinking about education pathways and developing yourselves, sometimes you do need to throw your hat over the wall and chase after it, and you don't really know where it's going to open up. I am absolutely mind blown that this just a paramedic, which of course I say to wind people up, the just a paramedic thing, and I've ended up as running a primary care network in the city centre of Manchester here in England. Absolutely extraordinary. So what we're going to do now is move on to talk about some leadership stuff, and essentially tonight's webinar I've entitled Prioritise, and we're going to keep coming back to this idea of prioritising and how we might do it, and why it might be important and useful. Probably first better to sort of try and understand why leadership is needed and what is the problem that leadership can overcome. Well, put quite simply, all problems require leadership, because all problems require change. So if there is a problem, there is a requirement for a solution, and implementation of that solution requires change. And the NHS definition of the difference between leadership and management is that management is business as usual and leadership is change. And I have to say, after 20 some years of being in various leadership roles, because this isn't my first rodeo as a leader, then I haven't come across a simpler and more pithy explanation of the difference between management and leadership. And it's very much one I'm going to lean into, is this idea that leadership is about change. Have to excuse me. Oh, please excuse me. I'm recovering from pneumonia, and I still have a little frog in my throat occasionally. So I think we've probably all experienced in a situation where it's become absolutely obvious to you as an individual that there's a need for a change. And it may even be particularly obvious to you what the solution is for that change, but the solution never happens. The change doesn't occur, and you keep going back into that situation, keep going back into that environment where there just hasn't been change. And I'm going to give you an example of that, just to paint a picture. In the early noughties, actually probably mid-noughties, I was at the front of an ambulance doing a blue light inter-hospital blue light transfer. I had a junior colleague with me in the back, And I put them in the back because in the back there was an anaesthetist, a fabulous anaesthetist I knew really well, an anaesthetist and an ODP, and bags and bags and bags of kit and a very, very poorly intubated, ventilated patient. And I'm tootling along on this fairly steady A road between the two hospitals. It was a route I knew very well, and literally right in front of me, in the frame of the windscreen of the ambulance, there was a motorcycle versus car. The car T-boned the motorcycle. Motorcycle went down, slid, and for those of you who've been on the road, you'll immediately be starting to sort of think of the devastating traumatic injuries that result, and they did. I stopped, got on the radio, called for help, jumped out, grabbed the response bag out of the back, said to the anaesthetist, "We're going to be a minute," and went to this individual. By the time I got to the rider of the motorbike, the bike and the rider had separated, and as you'd expect, the leg underneath the bike was severely injured, and the individual in question was hosing the red stuff all over the road. And this was definitely what you would describe a catastrophic, life-threatening hemorrhage. I mean, there was just no shadow of a doubt about it. Remember, this is early noughties, and the relevance of what I'm about to say will come apparent in a moment. I took the chap's belt off his waist and improvised a tourniquet on the bit of his leg that remained. Now, at the time, it's important to point out that I'm a military paramedic as well as civilian practice. In my military practice, tourniquets were common a garden. We'd been in Iraq and Afghanistan for a few years, and we had learned very, very quickly, courtesy of the team, many of whom are still around in healthcare. We learned that tourniquets save lives when it comes to compressible distal life-threatening hemorrhage. And so essentially what happened is the red stuff stopped leaking. Got some oxygen on the chap, the anaesthetist got a line in, etc, etc, etc. Second crew turned up, brilliant. I then spent about 5 minutes persuading them not to take the tourniquet off, because in those days tourniquets were evil and you weren't allowed to use them. They were the proviso of orthopods, and that was it. Managed to persuade them, having pointed out the amount of red stuff that was on the road, that the reason the patient was still alive is because there was enough red stuff still left in the core of the person, because it wasn't on the road, because the tourniquet was actually doing its job. And if you took a quick look at the leg, whether or not the leg was going to be salvageable wasn't a concern, because it clearly wasn't. Ambulance tootled off, went to hospital, dropped patient off. We continued on with our job. I had a little bit of a cup of tea and bit of chocolate when we got to the hospital, courtesy of the ICU team, bless them. And then, of course, after that, got back to station, and then it started. I was threatened with disciplinary action, performance management, the whole 9 yards, because tourniquets were not in the guidelines. And at the time, and arguably less so now, we were a very protocolized service. And of course, I was working for one of the statutory ambulance services. Nothing really came of it until the following month, when the mortality and morbidity meeting, which is the kind of the review of the complex cases, for those who are unaware, the review of the complex case review happened the following month at the hospital, and I was instructed to attend in uniform. So I go into this big lecture theatre. It's a lecture theatre I've been in for various training events at previous occasions. I recognised a few faces, some of the anaesthetists from when I've been in, because this is the hospital I trained in as a trainee paramedic. Some, obviously, a lot of the emergency medicine physicians, one or two of the senior nurses, but really not that many of them. And I plonked myself down in a chair and didn't really notice who was sitting around me, and waited for what I felt was the inevitable. I was terrified. I was on my own also. And a couple of cases were discussed, and then eventually the surgeon that had ended up dealing with this patient came onto the platform talked through the case from the point, basically from the point where the patient entered the hospital to where the patient was at this stage some 3 or 4 weeks later, which was basically doing rehab and surviving and being alive. And there was nothing about the pre-hospital care at all. Right up until the last throwaway comment by the orthopod, who basically said, if it hadn't been for the tourniquet, this would have been a discussion of a patient death rather than a patient's rehab, and that the ambulance service should be congratulated. Well, I was absolutely dumbfounded. I didn't have any words. I just sat there, didn't move a muscle. Sitting right in front of me was the head of the emergency department, the consultant in charge of the emergency department, who had largely trained me as a trainee paramedic and engaged with all the various departments in the hospital to get me the placements. And she was amazing. She just turned around to me and smiled, a lovely smile, and said, well done. And that was it. As far as she was concerned, that was, oh, yeah, well done, Rusty, off you pop. At that time, I saw in the corner the medical director of the ambulance service. I hadn't noticed she was there. Gave the curly finger, and again, my legs are shaking, and somehow I managed to not fall over all of these lovely people who were in this auditorium, go down to see the MD, go outside, and she's smiling, and she says, brilliant result. We've been looking for this for years. Over the course of the next couple of years, the civilian pre-hospital care caught up with the military pre-hospital care, and we had a change in guidelines. And then we had the introduction of the trauma networks that some of you may not have been around. Most of you probably weren't on the road or practicing prior to the establishment of the major trauma network in England and across the UK. And then in 2012, finally, in the run-up to the Olympics, the actual major trauma kits started magically appearing on ambulances. And in there were the cat tourniquets, the hemostatic dressings, the big field dressings, the big stopping the claret, keep the red stuff in. For those of you who are of an age, they may remember the expression for on the Miller course for trainee paramedics, for trainee technicians, for keep the air going in and out and the red stuff in, and going round and round, of course. So what we saw there is a multi-years, it took multiple years for this change that, quite frankly, now it is unthinkable for us to not have a strategy for managing compressible life-threatening hemorrhage. We even have strategies for managing non-compressible. They're just not quite as successful or as easy to implement. Nigel, you've nailed it. That's pretty much it. Thank you. So why did it take so long? But also, why was it successful? And Miller course first. I'm not a paramedic. I'm a technician who happens to be a paramedic, an ACP, and a prescriber. Actually, I'm a technician underneath all of it. So the point I'm trying to make is the time and the duration and the pain and the work that was involved in implementing this change, which now appears to be absolutely self-evident and obvious. But at the time, in the late noughties and in the run-up to the 2012 Olympics, it was very, very traumatic. And there were still, when those trauma kits arrived on the ambulances, there were still some of the old sweat paramedics saying that they weren't going to use them. Lots and lots of inertia, lots and lots of resistance. Now, the reason that there was a success in that case is the evidence, the life-saving evidence for the massive hemorrhage management coming out of the sad lessons learned in Iraq and Afghanistan, and meant that there was the overwhelming understanding, this overwhelming breadth of evidence that it was the right thing to do. And the right thing to do spoke to people's core values. And I'm going to come back to core values shortly. But what they also did is they didn't try and do changing the protocols, introducing the trauma networks, and introducing the kit all on the same day. It was spread out over a couple of years because these things take time. And the attempting to do it all on the same day would have resulted in failure, but it didn't result in failure, it resulted in success. And I'm sure there are many people here who've either seen or actually saved lives with tourniquets. So let's come back to this idea of visions and values. And what I want to get away from is the very branded, trust top-down vision and values that you'll see on posters and on the bottom of emails and various other places that these things crop up. And what I want to examine is what core values actually are and how we identify them in ourselves. So what I'm going to do is I'm going to ask you all now to imagine, or remember indeed, because we're going to reflect, remember and picture in your mind something that you have done that has generated a huge amount of satisfaction, value. It's something that potentially you might be appropriately level proud of. Picture something that was very, very meaningful for you when you achieved it, when you did it. So just sit with that for a minute. And then what I'd like you to do now is to try and look a little bit deeper and go, why was that meaningful? Why was that experience? Why was that success? Why was that occurrence? Why was it meaningful? What did it give me as a person? And what I'd like you to do now, if you can, for those of you who've kind of tried to start to piece this together, and it's not necessarily a 5-second reflection piece. This is something you may need to come back to many, many times to help work out what's actually going on. For anyone who's gained any insights or has any thoughts as to why significant events were important, we don't need to know what the events were. They could be very personal, they could be professional, it doesn't matter. It's something that's important to you and valuable to you. Can anyone start popping things into the chat to describe why that was important to you? What was it about that made you happy, made you feel satisfied, made you feel positive? Thanks, Rebecca. Brilliant, Claire, love it. Robert, can I ask you, if it's okay, what was it about the patient outcome? Why was a presumably positive patient outcome, why was that meaningful to you? What's meaningful to you about positive patient outcomes? Let's just strip it, let's just take it down to that next layer of understanding, if you can. If you can't, don't worry, it's all good. Kelly, why was that important to you? Your survival or theirs, Robert? Theirs, presumably. Thanks, Robert. Sarah, on behalf of the entire profession, thank you. There's probably nothing more important we can do than help students of any healthcare profession try and get through, because one of the consistencies in the NHS is a staff shortage, so we need to make sure we're supporting our students. Super. So these are lovely and positive. Oh, hang on, there was a longer one there. Let me just read that one. Nigel, what an amazing achievement. Thank you for sharing. Are you able to share or explain anything about why that is important to you? It's the why underneath the what that we're trying to get to here, if you can. Oh, Claire, brilliant, the trust word, thank you. Yeah, you were walking in someone else's shoes there, Kelly M, weren't you? Sorry, Kelly McGinty. There's two Kelly M's. Kelly McGinty, you were walking in someone else's shoes there, and it was that gift that you were that was valuable to you. Growing confidence. Yeah, other Kelly M, also awesome. Oh, Graham, nice one. Yeah, how did that feel? Let's have a little bit. If you can just open up a little bit more, if you can. Oh, Elaine, that's very meaningful, isn't it? When you get that sort of a comment from someone, and you realise that you can add value to your peers as well. That's absolutely fabulous. What I'm getting from so many of you, and thank you so much for sharing, is this idea of caring and giving, and that is completely consistent, of course, with a healthcare audience. I also like that a lot of you have talked about the impact on others, not just patients, but colleagues, and supporting others. Wow. Why not? Keeping our colleagues safe, that absolutely critical. Well done. Thank you. So we kind of worked out what's important to us. And I would tentatively suggest that there's a few more layers to unpeel there, but no rush, no pressure. It can take days, it can take weeks, it can take years. It took me years. Well, that's largely because I'm as thick as an oak tree. But and have a sensitivity of a lump of concrete. I got there, more or less got there eventually, I think. So having this understanding of what's important to you is really, really important for the next step. Because what I'm going to suggest is when you're trying to achieve something, achieving a change, and bear in mind the other thing about leadership is that leadership doesn't necessarily only come from job titles. Leadership can also come from all levels. So we are all leaders. We are all influencers, and it's in the context of that we're really talking. Is when it's time to get something done, there is quite often it's very, very easy to be completely overwhelmed by the task or tasks, and more commonly it's tasks. And we all have that in life, don't we? What should I be doing now? Should I be attending the webinar? Do I need to be completing the weekly online shop? Do I need to take the dog for a walk? Or should I be putting the kids to bed? What should I be doing right now? We've all got multiple demands on our attention at all time, and we're constantly having to do this prioritization. And what I'm suggesting to you is that when you prioritize in the context of something that's important to you, that you will invest in, because the closer the task's outcome meets your values, and your values being all of those layers underneath the why was that something important to you? Was it giving? Was it caring? Was it being gentle? Was it being generous? Whatever it is, and a lot of those words will apply to many people on this call because of the jobs that we've chosen to do. Ensure that those line up, and you've picked something that can be delivered in a short time frame, or at the very, very least, when you start doing something, you get some form of feedback to work out whether or not you're going in the right direction. Because the most important part of prioritizing isn't prioritizing, it's having the openness to change. So let's use Joanne's case. changing the way emergency checks are carried out in the theatre. And I presume, Joanne, in there we've got the WHO surgical checklist and various other things being implemented, and lots of these sort of human factors things being introduced. And I would imagine it's entirely plausible. And by the way, Joanne, perfectly timed example. It's perfect for this. That the introduction of these sorts of changes, you change something, and then after a week or two, maybe slightly longer, you work out they're not quite right and they need another change. So, Joanne, I'm going to ask you if it's possible. Did you have to iterate these checks and this plan and this new way of working, or did you manage to nail the design from day one? Let's see what Joanne says. Just whilst we're waiting to see whether or not Joanne's going to respond, I'm going to suggest that most of these plans are not perfect on day one, and therefore they need to be tweaked, they need to improve, they need to be iterated. Can I ask you to consider what sort of behaviours? Yeah, thank you, Joanne. Perfect. Feedback and change and update on a regular basis. I'm going to come back to that. That's brilliant. Thank you so much for the example. Put yourself in that position where Joanne and Joanne's team and colleagues are, that they're iterating a plan that they've come up with. What behaviour, yes, Nigel, the only constant is change. What behaviour is it that permits us to be open to that change? What behaviour, what characteristics, what feelings, what emotions? Can anyone share any thoughts about what that might look like? What mental state, what emotional state, what personal state do we need to be in order to take the feedback from the colleagues that Joanne has talked about so clearly, take the feedback from the colleagues, accept the feedback, because not all of it's going to be you're 100% nailing it, thank you so much, it's perfect, because clearly that's not the case, otherwise it wouldn't need iteration. And then openness. Unguarded, open, unguarded, and reflective. Thank you. Yeah. Anyone else got any thoughts as to what sort of mindset, what personal state might be conducive to allowing a person, allowing a team, or allowing a leader to be open to iteration and change? Thanks, Rebecca. Yeah. Oh, M. Bracken, listen, one of the most important skills of any leaders. Well done. Consume criticism like a fine wine. That's a lovely turn of phrase, isn't it? So yeah, absolutely. Openness, flexibility, consistent communication. Yeah, loads of really good stuff hitting the good communication. Loads of really good stuff hitting the chat. Absolutely, absolutely right, guys. So it's this is openness to change. Now let's go the layer below. What behavior do we need to have? What mindset do we need to have in order to have that openness? Okay, the H word has appeared in the chat, humility. And in order to be humble, we need to be self-confident. It's very, very difficult to be humble and open if you are feeling in any way vigilant or under threat or unhappy. And this is where I come back to the idea of the core values. If you are functioning in line with your core values, you will know that you are in principle on the right path. The actual detail of A, B, C, B, B, C, D, whatever you're doing may require some change. But if you've got that confidence, the humility that grows from the confidence, you will listen, you will iterate, you will reflect, and then we go into the cold learning loop. This idea of you do some, you see the outcome, you reflect on the outcome, you make a redesign, and then you act again and you go around this. And of course, in the NHS in the UK, this is commonly referred to as the PDSA cycle. Plan, do, study, act. And it is fundamentally the Kolb learning cycle in different words. And there are many papers. Nigel talking about roadcraft. Oh my God, that's taking me back. The one thing they drilled into us, the only good driver was the driver who could accept it. Yes, absolutely. Yeah. So it's that same principle, Nigel, but it comes from that position of calm self-confidence. And of course, self-confidence, when overdone, becomes arrogance, and we end up putting ourselves in a different box. But we're talking about this calm self-confidence, this humility, this ability to be vulnerable and accept that what you have produced first wasn't entirely right, and because you know you're fundamentally moving in a direction that's acting in the best interests of you and others and consistent with your core values, that becomes easy. Now, we've probably all seen exactly the opposite, where somebody's implemented a change and there's been an attempt either by us or someone else to provide some feedback, even positive, constructive, critical feedback, to say, that's a great plan, it's not quite there, a couple of extra components need putting in, maybe a component or two needs taking out. People want frank advice until they get it. Yeah, it's true. And I'm absolutely 100% guilty of that one. This idea of having that humility coming from that strength, because it's consistent with core values. So, guys, what we've talked about tonight, I'm going to open to Q&A in a moment. What we've talked about tonight is this idea of prioritizing workload, setting small goals, making small decisions, prioritizing the small decisions, getting some feedback early. There's no point implementing these, for example, these changes, the changes that Joanne was talking about in theatre, and then not reviewing them for 2 years. You want something where you'll get a meaningful amount of feedback and data if it's available, or whatever you have, and get that feedback in a shorter time frame, so you can iterate in a meaningful way in a short term. And of course, as soon as you start to iterate and change in that way, and you're demonstrating the acceptance of the fact that the plan A wasn't right, then you are setting an example, which of course is another huge component of leadership. So, core values, prioritize, and underneath it all, the H word, humility. What I'd like to do now is open up to Q&A. Yeah, I think we've got about 20 minutes left, Andrew, is that right? Open up for Q&A. Pop your questions into the chat, and we will see how we get on.
Rusty, thank you very much indeed. Have we addressed the question from Rebecca? Because she's got one in there already. I don't know if you can see in the Q&A box.
Missed. I shall scroll back up.
Well, I can read it out for you if you want.
Please do, buddy. Please do. I'm struggling. I'm on a small screen.
Oh, bless you. So we have an emergency bag in primary care GP practice. It became evident that this bag was not user-friendly at a recent emergency situation. I want to introduce a new kit bag. Any good ideas? I'm attending Basics in Scotland at the end of the month and hope that they have more intuitive kit that I can implement in practice.
So this is someone who's clearly read one of my essays from the leadership module of my MSc, where I actually did an audit of emergency kits across the 3 practices and urgent care centres that I worked at, and discovered that there was no consistency, even though it was the same organisation. There was no consistency across there. Rebecca, bit of a minefield actually. There are no guidelines for emergency kit in primary care. I would caution you against, I'm not sure what your background is, but if you are a paramedic, I would caution you very much against leaning too much into the ALS side of life. It's very much about doing the basics, but doing the basics well. A kit bag is one thing, but Rebecca, you're probably on board with the idea that a kit bag without training is about as much use as a wet rag in a thunderstorm. So make sure that whatever kit you're getting is going to be trainable across the spectrum of people who may respond at the practice. Now, in reality, the first responders to most emergencies tend to be not clinicians, because most emergencies tend to happen in waiting rooms. In that case, it's your reception staff. So not only is training important, not only is the training important, hang on, mate, I've lost the chat. Not only is the training important, but also the empowerment of those non-clinicians, that they don't need to wait for the clinicians to arrive to, for example, put the AD pads on and get on the chest. Because of course, and also empower them that they don't have to do mouth to mouth. Not only do they not have to be doing it, they shouldn't be doing it. And chest only CPR for a few minutes is almost certainly of no negative impact at all in terms of outcomes. And there's some evidence that it's chest compressions only is actually better than doing ventilations as well. Rebecca, does that start to answer your question? And you've already posted, right? Any more questions? Any more questions in the chat, Andrew? I haven't managed to stay on top to see if there are any more in there.
So we've got a question from M. In the motorcycle case you described, you went outside guidelines to save a life because it was the right thing to do. If it had not been a good outcome, do you think your situation would have been different pre-hospital, as added pressure of explaining after the fact? Very true.
Yeah. So I was in an incredibly fortunate position at the time that I was connected into the diploma in immediate medical care. I'd passed it and had become an examiner, and I'd started to meet a number of the luminaries of pre-hospital care, some of the authors of some of the books that some of you have read, some of the people that Andrew interacts with at trauma care. And when I kind of shared this experience with them, the overwhelming wealth of the overwhelming support was there. So I knew I'd done the right thing clinically. I knew I'd done the right thing morally. Stepping outside the guidelines in order to save a life, I always maintained that I would do that at the risk of my job, and I'd rather lose my job than lose a lifetime's worth of sleep, because I elected to put my job over someone else's life. And I have to say, that wasn't the last time that I stretched guidelines in the best interests of the patients, because for those of you who haven't been on the road for very long, you probably underestimate how limited we were, both in terms of scope and flexibility, even as short a period of time ago as 8 and 10 years. And of course, the two faces you can see are two paramedics who no longer work on frontline ambulances, and you can infer what you wish about why that might be true.
Hey, I've got a shift next week.
Oh, mate, gosh, just shoot me now.
They must be pretty desperate to want me to go and work on a frontline ambulance, but I'm looking forward to it. it.
You and I need to have words.
But you're absolutely,
we need to have words.
You're absolutely right.
We talked about the fact that you weren't going to do that.
There's a great comment in there from Kelly. I don't know if you read it out. You need to be good, open, reflective, and resilient, and a good leader would promote humility, positivity, empowerment, and good communication. You're absolutely right, Kelly. All of them things tick a massive box for me.
Yeah,
and
agreed.
It's just it's such a shame sometimes in NHS, because there's potential for such great leaders out there, and then they often do or say the wrong thing, and it just spoils it for me.
Yeah, can I just speak to that for a second, Andrew? Can I just speak to that one?
Yeah.
So for many people on this call, they may well not have job titles which include words like managers and leaders and so on and so forth. But the problem is, by the time you get those job titles, developing your leadership skills, it's already too late. And I'm sure, sadly, that many of us have had the experience, and I know Andrew and I have, I've had the experience of working for people who were, from a management and leadership skills perspective, way outside of their competence in the roles that they were put into. And that's an appointment error. It's not necessarily the error of the person in the role. Perhaps the only mistake they made was being ambitious and wanting to have a go. But systems that don't support and train their leaders are as at fault, if not completely culpable, in my personal opinion, for the fact that we have this situation and it's not unique to healthcare by any stretch, of a dearth of quality leadership, root and branch. There are fabulous leaders, and I'm sure we've all also had experience of working with some amazing people, and I'd love to name them. And that there's one or two very, very senior paramedics in Manchester who I would love to name, but I'm not going to. They're absolutely fabulous. But even the ones who seem to somehow manage without very little input and training, with a little bit of input and training, would actually be even better. So there's this whole nature versus nurture idea when it comes to leaders. And yes, there are certain people who, courtesy of their upbringing and their genes and various other things, have some of the qualities that, for example, some of the qualities that Kelly's just listed there about being open, reflective, resilient, good leader, promote humility, positivity, empowerment, and good communication. Some people have some of those skills seemingly naturally. We've all met people with the gift of the gab who've kissed the Blarney Stone. You can talk the hind leg off a donkey. But can they formulate a plan? Could they communicate the plan? Do they have the adaptability and the agility to change the plan when the call comes for the plan to change? So the nature versus nurture. Whatever your start state is in terms of being a leader, with work you will improve. And please be in no doubt whatsoever that leadership is a series of competencies in its own right and doesn't come without effort. And that requires investment the way that your clinical development has required investment. And for those of you who are considering going down the advanced practitioner route, I would remind you that leadership and management is one of the 4 pillars of practice that you will need to be able to demonstrate competence in, not only in your journey on the MSc, but also in your journey as an ACP when you're doing your appraisals and your validations or whatever processes you do with your employer and your registration bodies. So yeah. I hope that's been useful. Do we have any other questions?
I think you have. Is the right term bossed it? Is that the right term? Just one more from Alan. I have to say thank you. My staff today said they got a package from you, and so I'm not sure what it is, but it's the staff opened it this afternoon. They haven't told me what it is. It's on the windowsill, but thank you very much indeed. I suspect I might know what it is. Elaine said my ambulance service is very poor. Sometimes at debriefing and learning from certain situations, be it good or bad. Do you have any advice on how to implement some sort of case discussion setup? Oh, interesting.
Very good one. Very good one. I'm just going to echo Nigel's comments about Dick Winters. For those of you who haven't watched Band of Brothers and you want to see a real leader, and that's very, very much based on a true story, then please do so. I use Band of Brothers quite a lot when I'm teaching my military colleagues about leadership. Okay, so debriefing. Okay, debriefing is another minefield. We need to be very careful about debriefing. Compulsory debriefing and debriefing can be actually deleterious, can be negative, can actually impact, especially when you have forced debriefs. And I remember when I first started on the road, when debriefs were introduced, you had to have a debrief, and everyone was sat round, and everyone was, it was absolutely horrendous. And also, just in the interests of complete transparency, I'm a PTSD survivor, and I have spoken at conferences and blogs and podcasts and previous webinars and so on. And Andrew might maybe put some links into some of my other content about being a PTSD survivor into the chat at some point on a subsequent session. I'm not dropping you in it now, Andrew. We'll do it on another day. So you've got to be very careful. Firstly, you've got to be very careful with debriefing. Secondly, there's a timing issue about when you do it. If you're talking about clinical debriefing, purely clinical debriefing, away from the emotion of the incident to discuss how a particular thing went, the fact that someone decided to tube before they put a cannula in, or they did one thing before another, and how did they, what was going through their mind at that time. There are ways to do this. Black Box Thinking is an awesome book. There are ways to do this that that can be done positively. Probably the way to start, and I forget who it was that asked the question, was it Emma? Probably the way to start, Emma, is rather than talk about actual cases, is to talk about hypothetical cases and create the framework for the narrative around asking questions and getting feedback, and generate the culture of discussing cases that are hypothetical first, and then at the point where the process is appropriate. And by the way, there needs to be governance in this as well, so make sure you speak to the appropriate governance lead if you're going to talk about actual cases, and make sure that all the various governance requirements have been ticked, because they're not small, unfortunately. And then you can move on to talking about actual cases. You need to learn, when doing this, you need to learn how to have learning conversations, which is a technique in its own right. A coaching approach rather than a mentoring or teaching approach is usually most positive. And again, this is pan industry, it's not unique to health. But if you want to do an after action report, an after action review, a debrief, whatever you call it, and you've talked about the fact that the culture isn't there, I would tentatively suggest you need to start small and tweak, just to go back to that Prioritise example that we've been talking about this evening. And the smaller way to start it, rather than dealing with actual cases, would possibly be to deal with hypothetical cases. And instead of calling it a case review, call it a scenario-based learning or something else. And then if that's working, and if you're generating momentum, if you're generating some momentum for learning amongst your immediate group, then you can then, with, as I said, with the appropriate governance, start leaning into actual case reviews. But if you look at the governance, if you work in secondary care, if you look at the governance around morbidity, mortality meetings, it's not small, and content tends to be reviewed before it's shared, and you know, X-rays and CTs have to be anonymized, etc., 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 etc. So it's not a small piece of work. There is a big difference between that and having a quick chat around the back of the ambulance, or somewhere else about something that maybe you want to get off your chest. And again, there's no right or wrong there. Go easy, be gentle, do more listening than talking. I hope that answers your question.
Thanks, Rusty. Do you know what? That's really interesting. I did some consultancy work with a couple of organisations who struggled with reflection, really, because they always suggest that it's going to be Gibbs's or Rolf's or Carroll et al. And people who aren't particularly academic really struggle sometimes with that element. And they wanted something sharp, quick, simple, but equally so that they could talk about something that actually has not just gone wrong in their organisation, but equally something that's gone really, really well.
The amazing,
and, do you know what?
The amazing and awesomes, as opposed to the morbidity, mortality.
Yeah. It was a pleasure to work with them, because actually I could relate to some of the things that actually were going wrong, but equally could well and truly relate to the things that actually was a commendation, pat on the back for some of these individuals. Nigel just put the one thing, and possibly the only thing my trust gets right. Oh gosh, Nigel, is we have Schwartz rounds. Yeah, I've been involved in those. Well, every week, where we think. Where there's a specific subject and the subjects come from an individual staff, and sometimes we use them as a debrief.
And of course, Schwartz rounds are a formal structure that organisations that usually have formal nominated facilitators, hosts. I'm not sure what they're actually called. I can't remember. I've done a few myself. I have to say, the way it was implemented, where I experienced it, I only went to one, put it that way.
Comment from question and comment, in fact, from Kelly. When I was at university, we did a whole module on leadership theories and what type of leader you want to be. Do you? I think I probably did the same one, Kelly. Do you think?
Yeah. Was it just north of the M60?
Do you think it should be something that's taught within ambulance services to improve and empower leaders?
Short version of the answer is yes. Leadership development needs to occur at all levels of industry and health and public and private and service. Absolutely leadership. I have a team of 15 people that work for me, and all of them get leadership coaching, and some of them are less than a year or two out of non-health related undergraduate degrees, and they have job titles which include the word administrator, and they all get leadership training. The advanced clinical practitioner and the business development manager gets more than the adminers, but they all get some, because we're all on a leadership journey. And guys, I'm still learning. Every day is a learning day. I have been doing some personal learning development myself for the last 2 days. I've been away. I'm going to be doing over the next 24 hours is reflecting on that, and indeed tonight's experience, and working out how we can, how I can improve as a leader, as an educator, in my practice.
Rusty, thank you very much. Speaking about learning and leading, we have got some more webinars. Hopefully you can see my webinar screen. I used to put these on the presentation, but it's sometimes just better going live on the website because you can see them easier. So if you want to take part in some more of our webinars, they are listed from literally the 10th of March, which is tonight. We've got an amazing symposium, and we've got 2 tickets left for this weekend symposium. You can probably see the pop-up that's popped up on my screen for Dr. Deshana and Dr. Blanche this weekend, Saturday morning. And then we've got some more amazing webinars. In fact, if you look further down, you'll probably see series 2 of Rusty here on the 21st of April. For anybody out there who's a radiographer or works in theatres, we've got an amazing series by a new consultant radiographer who's just come on board, Graham. Medical image shoulder, artificial intelligence in trauma. I think it's talking all things drones and electronics. Must knows, QI, quality improvement. Don't know if anybody's interested in that, but we have got actually a colleague who I've done some work with NHS England, Tom Rowlinson. QI must knows in under 60 minutes. Gosh, I wish I could have had that lecture about 4 years ago. Medical images of the pelvis, amazing there for anybody in the radiography world. We've got some more Rusty here. Recruit, healthcare leadership. And then we've got, well, it just keeps going. We've got an amazing webinar, September the 13th, Aliens in ED, what hospital-based youth workers can teach clinicians on adolescent patient care, by Sean, amazing. And then we've got also Rusty again, July the 14th, quality assurance for medical practitioners. And then also standards of practice, why do we need to keep them? How do we upkeep them? Presented by Andrea Teresiano. So all that leaves me to say is, Rusty, thank you so much indeed for an amazing presentation.
You're very welcome, my friend. I'm looking forward to evolving the offer as we go through.
Indeed, indeed. And again, if anybody out there has got any webinars that you want to see, or you want us to cover any particular subjects, please do let us know. You can either reply in the chat, or you can send me an email. You know my email to team@cpdme.com or andrew.omrod@cpdme.com, and we'll try and line them up for you. We're having some moving and shaking with webinars, but trust me, we will make sure that we continue to bring you some quality learning. So on behalf of myself, the team here at CPDme, and of course, Rusty, our amazing presenter for tonight, thank you so much indeed, all of you. If you are at home, kick off your slippers, maybe pour yourself a nice peppermint tea, maybe pour yourself a glass of wine, whatever floats your boat on a Thursday evening. It is nearly weekend, so thank you so much, all of you. Enjoy the rest of the evening, be kind to each other, and thank you so much for supporting CPDme. Take care, everybody, and good night.